so he can build up his expertise in that field. The second one is, of course, I will explain to you all during my lecture what is important to be successful. And successful doesn't mean just to have a good healing result. Successful means successful long-term, 10 years, 20 years, even longer, 30 years. So I think last week, on Monday morning, when I see normally 3 new patients, one of the patients asked me, I heard that implants can last for 50 years. And I said, that actually we don't know yet. Because my oldest patients I treated in the mid-80s has just passed 35 years of follow-up. But I'm sure in 15 years, when I turn 80s, then I'm sure we're going to see patients with 50-year-old implants, I'm sure. We're not losing all of a sudden all these implants after 25, 30, 35 years. But to go such a long distance, you have to do a good job at the beginning. So 80% of the long-term success is in your hands. Of course, 20% is the patient's job. Hygiene, non-smoking, all these risk factors that can influence that. But you have to do a good job to have the best chances for long-term success. And I will explain that to you. And then, of course, the third point is that I'm going to show you all relevant aspects of implant surgery in these partial dangerous patients. Today, we talk about more the basics. Implant placement in healed sites, when everything is healed. Tomorrow we talk about bone grafting techniques, how to use GBR, how to use sinus floor elevation, also more complex stuff. Tomorrow I'm going to show you also how to fix aesthetic disaster cases. That's more for the master clinicians here. So when you get in a stage that you see many patients, you are very experienced, then you're going to start to see that patients send failures to you, to fix failures. And I will show that to you. Okay, what are the topics on the first day today? 4 lectures. So now we are talking about these relevant factors for successful long-term outcomes. And then I will show you a short lecture, how to select implants concerning type, diameter, length. Very important. Then we talk about implant placement in healed sites in posterior, mainly posterior mandible. Very frequent indication. Open flap when flapless, how to use a little bit on computer-assisted implant surgery. Today we are already in about 35% computer-assisted surgeries in our department. It's rising each year a little bit. It will never be 100%, but it is a very nice tool to simplify. And then today we also talk about aesthetic risk assessment and basic surgical principles in aesthetic science. That's the basis for tomorrow's discussion. On the second day, then we talk about implant placement post-extraction in aesthetic zone, very frequent. It's about 30% of our patients. Single tooth replacement anterior maxilla, very demanding. And there we see the most failures from an aesthetic point of view. Malpositioning, malaxis, exposed implants, really bad. Then we talk about implant placement simultaneous GBR in the mandible, posterior, anterior. How to use GBR in the mandible. Then we talk about sinus floor elevation, so posterior maxilla. That's also about 40% of implants replaced. Many patients get implants in the posterior maxilla these days. And then last but not least, how to deal with aesthetic implant failures. That is then the last lecture tomorrow evening. Okay, let us start with the factors. So when we analyze implant dentistry today, we can say Very positive, very positive. We are in a phase of routine. I would say we were in a development phase up to 2000, and then the routine application started. That's almost 20 years ago. In our department, we treat about 550 patients every year. So many patients, everyday implant surgeries. We have 14 surgeons in our department, including 8 postdoc students. More than 90% partial dentures, many baby boomer patients, also age 65 plus. About 65% of the implants are placed in the posterior. And about 1/3 is aesthetics. Aesthetic is very important for patients. So that's not the #1 indication, it's more masticatory function, that's there. Okay, when you look into our patient pool, we have published twice. When you see a red color, then only it's a publication. And we have done 3 times an analysis of our patient pool. 2002, 2004, 2008 to 10, and now 14 to 16. The third analysis is ready to be submitted finally by one of my postdoc students, and you can see that the patient's age has increased over the years. So the percentage of, let's say, elderly patients has increased dramatically, drastically. So when you are dealing with, let's say, elderly patients, it's clear that you have more patients with medical risk factors. For example, bisphosphonate kind of patients, that's a very big issue these days. Then we have dental risk factors. Then we have anatomic risk factors. And of course, we have smoking as a risk factor. The beauty is, I don't know how that is in Vietnam, that the percentage of smoking patients. In young patients in Switzerland, smoking is about 35% of the young population. In elderly patients, it's less than 10%, which is very good for us, because smoking is a big problem. So when they smoke a package a day, then patients have much more often peri-implant pathology as a peri-implantitis. When you look into the age, then you see here the shift to the left, or to the right from your side. So you get the green bars are increasing, and that shows then the median age in that patient pool was 61. That means 50% of our patients is more than 60 years old. I treated this year 2 patients aged 90, and both in really good shape. And you have to understand, you see, that patients are doing so much better in these kind of populations. That's with demographic change. It's mainly due to dentistry as well, because today patients have much less infection in the mouth, and patients have much better chewing comfort. These both are very important factors to get older. Keep patients free of infection and keep them capable to chew proteins, meats, I don't know what. So when they lose the chewing comfort, chewing ability, then they're going to lose weight. Muscle tissue disappears very quickly. So very important role of dental treatment. So we have many patients. ITI has published an issue of the ITI journal, treatment concepts in elderly patients. I don't know how many ITI members we have here. Who is member of the ITI? Raise your hand. Yeah, you should become member of ITI, because there you get excellent information. You can sign up as a member without any printed documents. Of course, if you need to understand English. So far there is no translation into Vietnamese. But if you grow this country to become a big group, then you have a chance to become an ITI section. I just read in 3 weeks from now, ITI board will meet again in Germany. And there is now a discussion to establish a new ITI section in Russia and a new ITI section in India. This will be then the section numbers 30 and 31. And they established a section the moment they have more than 300 members in a country. So when you work hard, then the leaders here of ITI, fellows of members, they form a group and they approach ITI to establish a section. And with a section you have more financial support and you can establish educational events. So I know it very well because I've been ITI president for 4 years. 10 years ago, and we established the concept of study clubs at that time. At that time we were 7,000 members, now we are 20,000. And it's going to increase. You can have a digital membership, so it's actually very low expensive. And you get everything digital, so PDFs and everything. Good. What are kind of indications? You see here the change. 50% of our patients are single tooth replacements. So patients are losing a single tooth and replace a single tooth. That is most important in this elderly patient group as well. So that these two 90-year-old patients, they lost a single tooth in aesthetic surgery. Both they come and say, you see, I cannot walk around with a gap here. Can you place another implants? Both patients I treated 20 years, 10 years ago, and they have other implants and they're doing great. So they got both a single tooth implant. So that's 50%. So I treated many patients over many, many years and they got here implants, here implants, here implants. They always come back to my department to get a new treatment when they lose a tooth. And that's how the business has been increasing over the years. Even this year, our growth rate in implantation is 15%. John is very happy about it. Replacing even more implants this year. Okay, when we look into the procedures, then you see here again the third analysis. 40% of implants are placed in healed sites. Also, we call them standard implant placement. So you put an implant in, low bone grafting. And you can see that in this group, about 4% were flapless procedures, no flap elevation. That's computer-assisted surgery. And this is going to grow towards 10%, I'm sure. It's increasing each year. Beautiful technique also in elderly patients. Can you imagine? Patients have medical risk factors. When you can do an implant placement flapless, then it's much less morbidity for an elderly patient. Then we use computer technology. And I will show you 2 or 3 patients like this then during this afternoon. And then we have about 40% implant placement with GBR. These are all aesthetic cases or posterior mandible. But most of them aesthetics. Very important. This is then the main topic tomorrow morning. And then it's less than 20%, but almost 18% is for sinus floor elevation. Posterior maxillary. Patients without enough vertical height. So you increase the height with a sinus floor elevation. Second positive aspect. That's the second slide. Implant therapy is highly predictable, but you need to follow the guidelines, and if you stick to ITI guidelines, you have very good recommendations. ITI is organizing every 5 years a consensus conference. And the consensus conference, the last one was in Amsterdam last year. 5 years before, it was in my home country, in Bern, Switzerland. And and then it was in Germany in 2008, Stuttgart, and so on. After each conference, ITI is publishing proceedings. And there you have, from different working groups, recommendations how to treat patients. And this is based on scientific evidence and clinical expertise. It's a combination. That means what is in the literature and what is experienced by top master clinicians. And they try to come up with recommendations. When you join ITI, you follow these recommendations, you're on the safe side. Because there is no cowboy techniques which is not documented. Be very careful. You see a lot of marketing in the market. I will come back to that. Okay. Second, implant therapy is much more attractive than 20 years ago. 20 years ago, the treatments had longer healing periods, patients had more pain and morbidity to get treated. Today, we can offer treatments with much less morbidity, shorter healing periods, which is very good. And the third positive aspect, we will briefly discuss it. You see, when I come back to Vietnam in 2 or 3 years, I can promise you I will then more talk about digital technology, because we are making fast progress with digital technology. And this will influence the future of implant dentistry as well. I will show you then this afternoon some of the insights to that. So when you look into the predictability of implant therapy, then we have made with Thomas Albrechtsson and Lars Seneby in 2012 an analysis of the literature and provided only studies with 10 years prospective documentation. And you can see here the publications for 3 different implant systems. When you look at the University of Bern, that's just from Bern, lots of work for myself and my team. You see that we started in 1990 with a 1-year publication. It was the first paper, highly cited. And you see when you go down the list, then you see that at the end, the name Chakri many times. This is my collaborator, and hopefully the next professor in oral surgery. And we know in about 4 weeks if the medical faculty will appoint her, and I'm sure they will. And you see, when you look into these papers, you see that we have multiple 10-year papers. We even have a 20-year follow-up paper. And you can see that the survival rates and the success in a high range. In a 20-year paper, the survival and success rates were roughly 90%, so 89.5%. These were the original patients I treated in the mid-80s, 86, 87, 88. Those patients we will see again now after 30 years. So that will give us a first paper on 30 years follow-up. That will be very interesting to see. And so, when you summarize this, the survival and success rates in these patient groups shows that after 10 years of follow-up, the range is between 95 to 98%. Or you can turn it around. The risk to lose an implant when you follow these guidelines is about 2% in 10 years. So out of 100, you lose 2 implants. When you look at the complications, so that means the survival rate, the percentage of implants developing a problem like a biologic complication, that means a peri-implantitis, so that's about 5% in our experience. You find in the literature, of course, complications with much higher percentages, but there the treatments were not done correctly, I'm sure. Case selection, surgical skills, surgical technique, whatever, were lacking the top quality standards, and then you get more and higher rate of complications. Okay, when we treat patients, I always say to have a successful outcome, long-term stability. This is the major, the number one objective of therapy. I call them primary objective. Very important. That's the highest hierarchy. But of course, we also tried to improve our treatment modalities, make them more attractive. So we want to do the least number of surgical interventions. We want to reduce the morbidity. We want to reduce healing periods. And we also want to reduce the cost effectiveness, the cost. Because when treatments are too expensive, then you limit the number of patients profiting from these techniques. So your main goal should not be to increase your bank account first. You serve your patients and then your bank account will increase automatically. But you have to be a successful implant surgeon. Successful, because then you get more and more patients. That's the key. So, now the negative aspects. There are negative aspects in the field, you see. We see too much marketing in our field these days. Facebook, and of course at lectures, whatever you see. And this is done by either companies or by colleagues. Very aggressive techniques, the latest of the latest, a new technique, no documentation, and they try to advertise and so on. So we see implants on the market, implant components, biomaterials without any scientific evidence. Copycat stuff, copies. So I can tell you in Europe now, the European community has tightened the rules now. Like FDA, like Japan has very strict laws. You cannot put anything on the market without proper scientific documentation. I'm applauding this because we see so much garbage on the market. And you have to be very careful. I know a lot of the garbage comes out of Korea, a lot of the copycat stuff. And this is very dangerous for patients. You have got to be very careful what you put into the mouth of your patients. These biomaterials should be well documented, very important. You have to be careful with new treatment concepts that are pushed through Facebook, from Facebook groups for them. And as a result of that, we have seen an increase in complication rates. We see, sometimes I'm shocked to see what patients have, and this is always due to bad malpractice. So patients come often to Bern and ask, can you fix the problem? And in most of these cases, you just have to remove the implants and start from scratch. So patients are suffering, they lost a lot of money, they're losing confidence in implant dentistry. When we get too many of these complications in the field, this is harming the reputation of implant dentistry. And I would not be surprised when politicians and the media start to argue against implant dentistry. They should argue against certain dentists who are doing a really bad job. So, too many complications are dangerous. When we talk about failures and complications, I also want to show that quickly. See, we have different failure modes in the field. And you see, you can have a failure by infection called peri-implantitis, progressive bone loss and suppuration. Second, you can have a failure from an aesthetic point of view, that is by recession of the mucosa. The next one is failure by disintegration, a loose implant. And the fourth one is failure by fracture. Today that's not a problem anymore. I have not seen in our department a fracture for more than 10 years. It has to do with the diameter of the implant and with the implant material, how strong an implant is, and so on. When we look into the frequency, you can see that most often failure by infection is the number one complication. And I'm telling you that most often improper surgical technique is the main cause for infection. I will come back to that. Second one is then by recession, quite often lately, has increased. Then very rarely, failure by disintegration, about 1% in 10 years, and very, very rarely these days by fracture. This is not a big issue anymore if you stick to certain rules. When looking to the infection stuff, you see you need to understand the risk factors for periimplantitis. Risk factors. So you should be cautious in a periodontal risk patients to treat. You can treat, but you have to be very, you see, not very offensive, you see, very conservative treatment and very tight recall system afterwards. Second, medical risk factors. Bisphosphonate intravenous drugs, very dangerous. Or of course, patients with chemotherapy, whatever you see. Smoking, big problem. Heavy smoker, more than 10 cigarettes a day. How is smoking in Vietnam? Big problem here? Smoking? Heavy smokers? You have many? A package a day or more, very frequent. Yeah. You have to explain to patients. When I see a smoker, I don't do certain treatments strictly. I said, no, I'm not doing it. See? Either you quit or you look for another surgeon. I'm not spending my time for somebody who does not really care about the future of that implant. So many of them, they quit. I twist their elbows and arms each time I see them. What about smoking? Stop smoking. Stop this stupid behavior. It's not good for your implant treatment. You get infection. Stop. And you can influence a lot your patient. Very important. Then implant surface. I will come back to that. When you have an exposed implant surface in the sulcus, you get infection. I come back to that. Then unfavorable local anatomy. When there is a lack of bone, you have to rebuild the bone. If you cannot do that, then you should not treat with implants. And then, of course, the patient side, also again, insufficient plaque control, poor oral hygiene. So a patient should know what is a toothbrush, how to use a toothbrush, how to use interdental cleaning brushes or flossing. Very important. That's how we do that. Okay, here you see some of these really bad infections. In Bern, we don't see many of them, but we get a lot of referred. And the periodic one with Professor Sam is our top expert. And I got this crazy collection here by Professor Sandy. And what you see here, you see drastic bone loss due to peri-implant infection called peri-implantitis. And you see always exposed rough surfaces. The rough surfaces. Look, this one. This is the most severe I have seen lately. This is a Swiss lady. She came to Bern with infections. She was treated in the United States, in Florida. She said in a center, she went there always in winter time to have the warm temperature from Florida. In Switzerland it's very cold. When you have, when you feel your legs, then you move to the southern hemisphere. So actually, he went to Florida, had a toothache, and then she went into a dental clinic, and then the dentist told her, oh, you are in an age that you should remove all your teeth and put implants in. Then never a problem again. So I don't know how she got convinced. She had an extraction of the maxilla, immediate placement, immediate restoration. She spent $60,000 US for this shit. And 3 years later, she came to Bern and had this infection. All implants had to be removed. All infected, none of them with bone anchorage. And you see, she spent a lot of money, and of course she was devastated by the result. Spending so much money and 3 years later, such a bad situation. All infection caused by poor treatment. Second one, aesthetic failures. We talk about that tomorrow. This is mainly malpositioning of implants. Implants too far to the buccal, oversized, no buccal bone wall, so you get a recession. Beautiful, very ugly. Patients are smiling and you see the metal, that is a disaster. So the patients start to smile like this. That's how they smile. And it's no quality of life anymore. So look here, I will show you tomorrow how to treat. Most of them we treat, not all of them. Okay, disintegration. That's also another one we see from time to time. Not very often, but I learned that occlusal loading is more important than we thought. We will talk about that. So patients with bruxism are at risk, heavy bruxing patients. Then you can have an insufficient bone-to-implant contact surface. That means too short of an implant, single standing, disintegrates very fast. Or also risk factors when you have a fixed restoration supported by implants in the opposing arch. So you have implant restoration. That's a risk factor. Very important. Lack of occlusal adjustments. That's what we have done probably lately. We did not care enough for that. So I tell now my prosthodontists, check the occlusion every year. When there is a very tight occlusal contact, weaken it. Very important. And another risk factor is time. This is not a 1 year problem. This is a problem after 5, 10, 15 years. So the natural teeth, they show some attrition. You see, you lose height, but you don't lose height on your implant crown because it's a ceramic restoration. So this is the problem. So here you see some examples. Here you see this is a 26-year-old problem. After 26 years of function, 2 shorts, splinted 6 mm, got disintegrated. All of a sudden, she was biting on a hard stuff, pain. Both implants mobile. 26. But you can see there is a very fine line between the implant surface and the bone. So this is disintegration. The other one is only 18 months, very unusual, heavy bruxing. But you see the implant was placed in a malposition too far to the fascia with an intact buccal wall, but very thin, it fully resolved. And then of course there was no osseointegration on the buccal aspect. And the bruxing patient, it took her 18 months to disintegrate that implant. Very unusual. But you see the anchoring surface has not been really much. Okay, so when we now start to talk about the factors, see, I want to point to this diagram. This is from an ITI treatment guide, number 3. It was a chapter I have written with Stephen Chen from Melbourne, the current ITI president. See, Stephen Chen, excellent periodontist, a very smart guy. He travels the world in the moment as ITI president. He was just in Spain. I go to Kuala Lumpur, Southeast Asia. He will be in Southeast Asia, as in Malaysia. Next Thursday, Friday, Saturday is a 2-day congress there. And I heard we have also a group from Vietnam there. And he's traveling the world. We came up and said there are 4 circles that influence long-term success, treatment outcomes. That's the clinician. Since I'm talking about the implant surgery, I call it the implant surgeon. Then it's the patient, it's the treatment concept, and it's the biomaterials. And we'll talk about these factors now. And when we talk about the implant surgeon, I mentioned that already, that's 80% of long-term success. Got to do a good treatment. Otherwise, you don't have good long-term success. And that has to do with your skills level. You need to have some surgical talent, good education, and of course enough patience to establish experience. If you have only 5 patients a year, then don't do implant surgery. Look for a colleague who can do the surgery for you, and you just do the prosthetic work. Because you get more and more patients also with this setup. In Bern, I have about 5 colleagues. I do all surgeries for them. And in the city, they are known to be implant specialists. But they just do the prosthetic work. But they were very happy about that. So they go there, they get surgery done at the university, prosthetic in private office. So they talk to each other. Patient comes to the dentist, surgery, oral surgery, implant prosthodontics by the private dentist. So when you don't have enough patients, team up with other people who have enough patients. Because you need to have, I would say, in the long run, should do 50 implant surgeries a year to get into a master category. Very experienced implant specialist. Okay, so I go through this list of key elements. Now I have to check my time here. Oh, we have. Good. About 20 minutes. Good. So these are the points I want to mention to you. These are the key elements of success. And the first one is the pre-operative analysis. When you see a patient first time, a patient has a single tooth gap or has a tooth to be removed, you have to analyze the patient very carefully. And this is now the circle on top. So you analyze the risk profile of this patient. How is the medical situation? Any medication that could be difficult? What about the dental risk factors? Perio risk, occlusal risk, bruxism. Then anatomic risk, volume of bone, gingiva, keratinized mucosa, bone height, bone width, and smoking, as I said. So you analyze. So this is daily routine, to do a careful analysis. The goal of that is that at the end, you know, this is a low-risk patient, or this is a medium-risk patient, or this is a high-risk patient, very difficult. So you know exactly how the risk profile of that patient is. When we have anatomic risk factors, then we take often today a 3D radiology called cone beam CT. That's about 60% of our patients get a cone beam. It's very important. So the cone beam, we are using a Japanese machine, Akitomo, from Morita. That's the best company on that field. I know of excellent quality. So you see, this is the machine we are using today. It's called Akitomo 170. That's the right one. This machine gives you different volumes. So I love to use the small volume when the patient is young. So a post-trauma case, I don't want to have the huge volume because of radiation exposure. So you need to have a small volume, 4 by 4 centimeters, and gives you an excellent image quality, as you can see. But when you have an entire maxilla, then I take 4 by 8, so you can show the whole maxilla or the whole mandible. And then I want to see both maxilla and mandible. I take an 8 by 8. Then I see all teeth. So, very important. Choose a correct surgical approach. When you have established your risk profile of the patient, then you have to think about how to treat. And you see that is then the circle to the right, surgical approach. So you try to minimize morbidity, so you try to think, can I do that procedure? Standard placement, no grafting, yes or no? That would be my first priority. In many cases, 40% I can say yes, we can do. So this is implant placement, standard technique, no grafting. Then I have the other 40% implant placement with GBR. That is either simultaneous or staged. One surgery, two surgeries. And then implant placement plus sinus for elevation, both simultaneous, staged, depending on local anatomy. So you go for evidence of these procedures. You see, you establish how difficult they are, and you also know the risk involved. And then you ask yourself, can I do that myself, or should I better refer to a more experienced colleague? I send about 5 patients to experienced colleagues a year, to maxillofacial surgeons. Patients with extreme atrophies, I don't treat. I give them to more experienced max-fat surgeons. Is that a problem for me? Of course not. So I want to do the best for my patient. That's important. Serving the patient is the #1 priority of your professional life. Not serving your bank account, serving your patient. As I said, bank account is increasing automatically when you do a good job. So we call it an SAC classification. This has been established by ITI in the mid-2000s. And you see here, this is the book of ITI about SAC classification. It was published in 2009. Tony Dawson and Stephen Chen from Australia, main authors. These days, they are working on the 2nd edition of the SAC book. Again, Tony Dawson and another colleague. And it will be published within the next 6 months. An updated version. Okay, then last but not least, the biomaterial selection. That includes the implant itself. When we talk about the implant selection, then it's about the implant shape, it's the implant length, it's the implant diameter, and it's the implant surface. All 4 factors are important. Then we talk about bone fillers, autogenous bone, allografts, see other bone fillers. We'll talk about that tomorrow in detail. And it's about barrier membranes, GBR membranes, resorbable, non-resorbable, reinforced, non-reinforced, many questions. We'll talk about that tomorrow when we talk about GBR. Okay. When we talk about implant selection, then the titanium is still our material of choice. We use zirconia implants, but very small percentage, about 1%, only on strict demand by patients. Not very big demand in Switzerland. We have clear preference for screw-type implants with a thread, because that improves the stability at placement. So it's better primary stability. And we need to select proper dimensions. Implant diameter, platform diameter, very important aspects, and the implant surface. Today, I will show it later on. Modern implant surfaces are micro-rough and hydrophilic. And here Straumann has the best surface on the market called SL Active. I will show to you later on. We use mainly SLA surface. We use in a certain percentage also Toman implant system, but that's less than 10%. And this is Inicel, also hydrophilic surface. See, when a patient is referred to us by a dentist and he asks for Toman medical implants, then we put a Toman medical implant in today. So that's about 7–8%. 92–93% is Straumann implants. In Switzerland, it's a Straumann country. That's not a big surprise. Okay, so this is the development of Straumann implants. I will talk about that then later on. You see the whole development over the years, 86 through the 90s, 2011. These are all so-called tissue-level implants. As I will show in my second lecture, that's 80% of our business. 80%. Why so much? Because of the fact that these implants have a machined neck and a micro-rough body. We call them hybrid design implants. Smooth micro-rough. Then we have the so-called bone-level implants. They were developed with our help in 2005. The first bone-level implant was placed on Earth in Bern in December '05. Then standard diameter, small diameter, and now bone-level tapered. We also use them in special indications. They have no machined neck. They're just all the way up, micro-rough. A little problematic sometimes. So we'll talk about that later on. Okay. Then we put them in a correct position, very important. This is called restoration-driven placement. Very important. And you see, this is the diagram from a very famous paper, ITI consensus paper, 2004. Almost 500 citations in the literature, highly cited paper. And I will talk about that then at the end of this day and tomorrow. And the aesthetics are most important to have good aesthetic outcomes. An implant in a bad position will never be aesthetic. An implant in a good position can be aesthetic, but sometimes it's not. And this augmentation is not done correctly. Okay, next one, very important one. The implant should be fully embedded in bone. So you have osseointegration on 360 degrees of your implant. Very important. So, and that's part of the basic principles of implant surgery. You see, the first one we already discussed, and that will be a topic of itself, select an appropriate implant. But then the third point is that the implant should be fully embedded in bone, mainly on the buccal aspect, because there is often resorption. So, on both sides, lingual and buccal, when it's a mandibular implant. When we have implant placement, we have two different types of implant placement from a surgical point of view. You place an implant in a post-extraction site, and the alveolus is still there, partially there, but not healed. And you have implant placement in a healed site. Now, post-extraction implant placement, we're going to talk tomorrow. Post-extraction placement, aesthetic zone, mandibular zone. But placement in a healed site, that's today. And there we differentiate today a thick buccal wall and a thin buccal wall. And now listen very carefully, this is new, that's new material. This has been modified in the last 3 years. Because we thought for many, many years a millimeter of buccal bone is enough when you place an implant. Today I know that's not enough. You need 1.5 millimeter. I will explain it to you. So when you put an implant in, I will show you that then this afternoon. You see, you make sure that your implant goes inside the bone and it's a healed site. And where the SLA surface starts, the thickness of the bone should be 1.5 millimeter. So when you put the implant deeper with the SLA surface, and that's my strong recommendation, 1 millimeter, 1.5, then at that level it should be 1.5 millimeter or more bone thickness to maintain that bone, otherwise you lose it. And you see in a new study, not published yet, but in a review, this was beautifully shown. When it's a thin buccal wall, you see after 3 months of healing, there is no bone there anymore. This is an animal study done in Spain, together with Alberto Monche, one of my ITI scholars. So the main findings was that you needed 1.5 millimeter to maintain the bone. I will explain to you why. And this is a beautiful animation video done by Alberto with my help. And you see that you need 1.5 millimeter. When it's thin buccal wall, you want to see a complication. And you will see how that works. So this is a thin buccal wall, it's intact at surgery. And you think, yeah, this is going to stay there. And many colleagues think like this. But as you will see, this is wishful thinking. This doesn't work. Okay. So the implant is placed. Okay. Implant goes in place, covered up. Okay. You see a thin buccal wall. It's fully intact at surgery. Now what's going to happen? You see that bone is mainly cortical bone. And you see the spongy bone on the other side and the spongy bone further down. And of course, there is mucosa on top. Okay. Now, when you think about it, you need to understand the biology. The bone has blood supply from the periosteum. This is periosteal blood supply. And the bone has blood supply from inside, from the endosteal, it's called. So when you elevate the flap, you rip apart the periosteal blood supply. When you put an implant inside, you block off the endosteal blood supply because there is no blood vessel anymore, because it's a dead body called implant. So from both sides, you stop the blood supply. So then that bone gets into a vascular necrosis. The bone has no blood supply anymore. So the bone dies. And signals out, I'm dying, I have no blood supply. What is the body doing? They send in the troops of osteoclasts to get rid of the necrotic bone. That's what happens. Okay. So here you see that the bone resolves. And you see what happens then. You have an exposed micro rough surface in the soft tissue area. Okay. So this exposed micro rough implant surface is a big risk factor for plaque accumulation and the development of a peri-implant pathology called mucositis, peri-implantitis. Doesn't work, doesn't happen within a week or so, it will take time. Sometimes it takes 3 years, 5 years, but then you have your big problem, because then it's an infected implant. So here you see that in the animation, so implant crown gets on top, and then it's not moving, why not? It stops here, I'm sorry. I'm sorry, the video did not follow through. But what I wanted to show you, this exposed implant surface is a risk factor when the micro rough surface is not covered by a bone. When it's covered by soft tissue, then there is a communication from the sulcus on top. The bacteria work down the way to get on these surfaces, and then of course the surface becomes a big disadvantage for you. And the rougher the surface, the higher the risk. When the surface is very smooth, it's a very low risk to get infection. If the surface is very rough, a higher risk. If the surface is even microporous, it's the biggest risk. That's like kyanite. You can hear from in the field, kyanite has a lot of infections. In Bern, in the pros department, we have had kyanite implants placed up to 2014. Then the chairman changed, and we quit. And today we have many patients, 5 to 10 years of kyanite type implants. Major infections. We treat a lot of them, take all implants off to retreat them. So we quit completely these kind of implants because it's been very bad, very bad. Okay. So that surface should be smooth, smooth. Good. So that's why I say this combination of machined micro rough in the posterior in particular is a big advantage. So put the SLA surface below the crest and have the machine surface in the crestal area. I do that for more than 20 years. In the beginning we have had TPS surfaced implants, and then we put them at the crest level TPS. And then we started to see some problems because the bone resolved a little bit and then TPS got exposed. So then I figured out it's better to put them deeper. So 98 we made that change when we started to test SLA surfaced implants. So this stroma tissue level implant is a hybrid design implant. That's a terminology established in 93, I guess, 92 by Dennis Kahn from New York University at that time. And of course, many other systems have also hybrid design implants. See Tommy Medical, a III normal replacer, always a machined neck. That should be the favorite in the market. And I hope that in the future, companies will recognize this and listen to the researchers and the clinicians who have long-term experience to convert their implant system. I hear from Straumann that by mid-year, they will have the first prototypes of bone-level implants with a machined neck. I told them for 5 years to do that, and finally they are listening. So the mountain is moving, as I say, the big mountain called Straumann is moving now, finally. Very good. Okay, so you see when you put these implants in, if it's a thin wall, it's very thin. After healing, you get a recession. And then you increase your risk. When you have a thick wall, you get a little bit of remodeling on top. Everything is fine. Soft tissue stays at the right level. And everything in the sulcus is machined. We will talk about that this afternoon in more detail. So the take-home message, don't compromise on that issue. Very important issue. When you look into the literature, even you have indications. This is a very famous paper by a Swedish group. They looked into the percentage of complications, and they figured out on a huge patient pool, 3,000 patients. You see that they have had here different implant systems. So Straumann had the best performance, but was a tissue level implant. And the two other ones, Noble and Astrotech, were bone level implants, not hybrid design. 4 times higher percentage of complications from a biologic point of view at 9 years of follow-up. So stick to hybrid design implants. Okay, next one, put implants in a band of keratinized mucosa. Very important point as well. You see there is a consensus that nice keratinized mucosa is a factor that helps you to maintain an implant better. It facilitates the hygiene of the patients. It gives a tighter adaptation of soft tissues. And it has been shown very nicely. In the maxilla, this is not a big issue in standard cases. It can be a problem in failed implants. There is no keratinized mucosa. I will show tomorrow how to fix it. It can also be a problem in the posterior mandible, sometimes very small band. Then you have to do soft tissue grafting to re-establish keratinized tissue. And in the literature, we have several reports, long-term reports, where it documents that the existence or the presence of keratinized mucosa is a prognostic factor for long-term success. Okay, you see, this is the big problem we have when we have failed implants. So we do a lot of soft tissue grafting in failed aesthetic cases. I'll show you tomorrow how we treated that patient here. Okay, And the last point is then a non-surgical point. That is that when you have completed the treatment, the patients have to be integrated into a recall system. That's called maintenance care program. And I don't know, I'm sure you don't have too many dental hygienists here. This is done by dentists or by dental hygienists. In Bern, in Switzerland, we have a lot of hygienists. And we see these patients frequently. So again, you analyze your patient. How is the risk profile of that patient? Is it a patient with a periodontal risk? Is it a smoking patient? So it's a higher risk, then you see them more frequently. If it's a low risk, you see them every 6 months for a hygiene control. You have to help your patient to do a good job. You explain everything and so on. Okay. Here we see a long-term study by Raguzzo from Italy. And you see, he could beautifully show, you see, when you have a periodontal risk population with no hygiene, then the percentage to develop periodontitis is more than 50% at 10 years. So much higher risk to develop pathology. So you have to be very careful. Okay, so the supportive care program, maintenance care program should be established by the restorative dentist most often. Also the dentist who keeps the patient in recall. The frequency, the recall interval depends on the risk profile. So every 3 to 4 months in a high-risk patient, every 6 months in a low-risk patient. Really paid off. You maintain much better your implants, I can promise you. Here you see one patient at 18 years and you see hygiene, superb. Using a floss every day, to do a floss 20 seconds, that's it. That's not much. And you can maintain. Even another case, 25 years. That's the first aesthetic case we treated with Professor Belser. Look at the quality of the tissue. 25 years. We have many of those patients. So that's very important. Okay, when we summarize, I wanted to show you for long-term stability, it's very important to follow well-established surgical aesthetic protocols, evidence-based, or follow recommendations by academic groups such as ITI, where you have these recommendations based on evidence and master clinicians' experience. Second, you have to analyze a patient very carefully, pre-operative analysis, to establish risk profile, so you know what you are dealing with. Then choose an implant, an appropriate implant. I will show you how to do that in my next lecture. Insert the implant in a correct position. We'll talk about that tomorrow, also this afternoon. Then make sure the implant is embedded in bone circumferentially, 360 degrees. You need a thick buccal wall. If it's not there, build it up or reduce the diameter of the implant. That's the other one. Then choose an appropriate healing period. We will show you that, submerged, non-submerged, that will come next. Then keratinized mucosa is a prognostic factor that helps you. Appropriate healing period, and then keep the patient in a good maintenance care program when the treatment is completed, or supportive care program. Those terms are used in the literature today. Okay, that is my first lecture. We have now half an hour of coffee break. Then we have